Good night.
The Delta variant was yes. I'm unmuted.
Hi, good night, everyone. I think we're hearing Dr. Strisiver just fine.
You're hearing me?
Yes.
Good. Okay. The Delta was the less contagious of the two, but the more virulent. We saw that with the hospitalizations, the admissions to critical care, intensive care, and sadly, with the mortality rate. Viruses mutate. These are simple genetic errors in their reproduction. It's expected, and mutation can give you any end result. In this case, we've mutated to Omicron, which thankfully has been less contagious and less virulent. To me, it's been a good thing. It's allowed us a breather, and I think that we really need to take advantage of what has been really a very, very good hand that's been dealt to us here. Hello? Yes? I'm waiting. I think I had finished the contribution there, you know. The difference is really one of virulence and contagion caused by mutation of the virus. So we can expect more mutations. There are, I think, 2 developing in South Africa at the moment. One is even more contagious. But contagion does not equal virulence. And I think that is the saving grace at the moment. I think it also allows us a break to get children into schools. You're going to talk about it, Rajiv and Kathal,
Yeah.
but I've read that 85% of children in the UK have developed natural immunity, you know, but I would like you all to address that. I will just address the Delta versus the Omicron, which I think is a very simple topic.
So, good night. I just wanted to give a little background showing on Dr. Strisiver. Dr. Strisiver has been a frontline physician. He works in North, and he's been a colleague of mine who had the courage to see COVID-19 cases throughout the pandemic. I myself started seeing cases in May 2020. And at first it is a very fearful endeavor, but then afterwards it is an honor to witness and to serve patients who many times feel that they're in dire straits, and some certainly did face a difficult course with COVID. Of course, this included many adult patients and some children as well. Over the time, the treatment protocols have changed, but over the last few months since January, we have seen a reprieve. And I was recently having a conversation with one of my colleagues, and he was saying that, you know, the lady who brought Omicron into Trinidad and Tobago should get a medal for doing so. Because if we remember clearly, in December, the country was being ravaged by Delta. And you could see that actually our death rate in December, around December 20th, we had actually had the highest death rate in the world at 146 deaths per million per week, the highest death rate in the world. And spontaneously, it would seem as if that death rate resolved over the last few months. And this has a lot to do with Omicron. Omicron is a virus or a variant that is significantly different from the other variants that came before it. And internationally, in countries which have a decent amount of natural immunity, you can see that the death rate has fallen, and the vast majority of patients recover. In fact, the death rate in Omicron is one-tenth that of Delta. So to me, it has been a watershed. It's been a great relief to us. After going through the trauma of both the Gamma and Delta waves, finally I was able to breathe a sigh of relief in the last 2 months. I have not had any cases, adult cases, who required hospitalization over the last few months. I've had many children. Omicron is extremely contagious. It's about 1.5 times more contagious than Delta. The secondary attack rate, meaning the number of persons that would contract Omicron at home, is about 1.5 times more than Delta. So it's a more contagious, but much less deadly strain. I would defer to Wayne to perhaps talk a little bit about where the virus likes to replicate, but I can tell you it does not have, converse to or contrary to the previous variants which like to replicate in the lungs. Omicron appears to have an affinity to the upper respiratory tract or even the gastrointestinal tract. Patients coming with things like gastroenteritis, they may have a headache, they may have a bit of vomiting or perhaps a little diarrhea, and they have a sore throat. So clinically, it appears as if COVID, this entity called COVID, is very different from what we first saw. Yeah. Chauvin, are you all hearing me?
I'm hearing you perfectly.
Good. Good. So Chauvin, what we can do, if we can have Dr. Labastide and Dr. Bratt just on mute so that we can just interact spontaneously.
Yes, good night, everyone. Okay. Very much. I'd like you to talk a little bit about the difference between natural immunity and vaccines, vaccine-induced immunity. We've been studying the immune system. I mean, most of what we know about the immune system now we've really discovered over the last 40 years or so, and a large chunk of that has been because of the need to deal with HIV. So we put a lot of resources and energy into understanding the immune system. And it's a really sophisticated toolbox of responses because there's a tremendous spectrum of challenges that the body faces living in an environment with all sorts of microbes and toxins, etc. So we really have an enormous toolkit of bio weapons, if you want to call them that, or bio defenses that are really sophisticated and very versatile. Now, it was observed a long time ago, maybe as early as the 1500s or so, that people who who were affected by certain infections during the subsequent waves of these infections seemed to not be affected at all or as much. So it was clear, even though there wasn't much understanding of the immune system and how it works then, it was clear that this was an adaptive system, that there was some benefit to previous encounters. Now we know how that works. And vaccines were really designed to mimic the natural process of acquiring an infection, recovering because the immune system learns from that encounter and is better prepared to defend you on a subsequent encounter. We often, though these days, seem to forget that we have such a sophisticated and reliable and powerful set of defense mechanisms, and we behave sometimes as if it doesn't exist at all. So a couple of things. Vaccines were intended to try to remove that painful process of actually getting the disease. And if getting the disease and recovery is the best way of getting the most robust and long-lasting form of immunity, then if we could avoid the types of conditions in which you have short-term or long-term debilitating effects or high fatality rates, then clearly a vaccination is a good strategy. However, we have never been able to get a vaccine to provide as powerful and long-lasting a response as natural infection and recovery. That has never happened. That still has not changed, and the evidence still points in that direction. So there is a case for allowing natural immunity to happen whenever that is possible. Now, natural immunity responds to every available part of the pathogen, not just selected parts. So the other thing I need you to know is that there are different, most of us have heard about antibodies. If we haven't heard about anything else in the immune system, we've heard of antibodies. The body generates these proteins that can actually bind and cause things to happen to eliminate pathogens and so on. Now, it's important to know that we have different kinds of antibodies and they protect different aspects of the body. So if something affects you through your respiratory tract or your gastrointestinal tract, there's a particular kind of antibody called IgA that resides out there and helps to protect, because it survives even in the environment with your protein enzymes and so on that break down the things that you eat. Antibodies are proteins, so you need a special kind of antibody to survive and protect you in those environments where your GI tract and so on, where you have all these enzymes living, and IgA is what protects that. So a respiratory virus like these kinds of coronaviruses, you need IgA to protect. Now, when you put a vaccine or a gene therapy or whatever it actually is into your body through the intramuscular route or through the blood, you don't get IgA, you get IgG. And IgG is not present, it's not available in the GI tract or the respiratory tract where it can actually block these viruses from infecting you. So a vaccine strategy that depends on intramuscular injection was never expected in the scientific rationale to be able to stop this particular kind of infection. So it's not surprising to see that these vaccines or so-called vaccines do not actually prevent infection and do not actually prevent retransmission. So we have an opportunity here. I reiterate what Rajiv said. We have an opportunity here. We have a less virulent variant that is more infectious. This is an opportunity to allow our population to get to natural herd immunity, which is the only option available to us, in my view, at this point. We're not going to get there through these vaccines. And natural herd immunity is the only way that I can see that we can get to any semblance of the life we had before this pandemic. So,
Dr. Labastide, I noticed that the JVCI, that's the UK body that's responsible for the overseeing of vaccines, and safety of vaccines, they noted that about 85% of the children actually got natural immunity
Yes.
during Omicron.
Yes.
It would appear that they could not vaccinate faster than the spread of the virus.
Yes.
I couldn't help but notice as well that their education system has been very resilient for Omicron and even Delta. I think that the pediatric mortality and morbidity rate has been exceedingly low. I believe, I'm sure when you might, maybe you can get Dr. Bratt in here to give his take on what he's been seeing as a pediatrician.
Right, I think I am unmuted. Am I unmuted? Can you all hear me?
You can hear me.
Okay, so
Good
well,
night,
good
Dr.
night.
Bratt.
Good night, everyone. Good night to the panelists and the people who are helping us put this on, and good night to everybody who is listening or looking at this. We're very happy to be able to join this panel discussion. It's something I've been wanting to do for some time now. And I just want to, before we get into the nitty-gritty of COVID and children, I just want to raise a point, and that the point is the fear factor that has taken hold of the world and of the country and of all of us, including many doctors and nurses, and which I think is hindering our rational response to this outbreak. I do have to say I'm not going to lay claim to knowing who is responsible for this. But I do want to make the point that the medical profession in particular has not been very supportive of the public during this pandemic. Specifically, our medical association seemed to have vanished from view very early on in the pandemic, despite my efforts that I made to contact them, to ask them to make statements about what was happening. And everyone seemed to have given up to our Ministry of Health, which has very qualified people. But sometimes that it's not enough to have, when you have a small group of professionals living and working in a single building, who are making all the decisions about medical matters that affect 1.5 million people. In other countries, England, for example, they have something called the SAGE Committee, which comprises of about 30 different scientists from various backgrounds, not only the medical profession, who all gave advice to the chief medical officer and the people surrounding him who were handling the outbreak. And this is something that unfortunately was not done in Trinidad. I don't know whose fault it is, but it's, I think, part of the reason why the public is so scared is because they have not had the support from the medical professions. And this is what I think we're trying to do today. So I'm just going to address some of my remarks to COVID in children. I've been doing this for the last 2 years. Anybody who wants to know what I've been writing, I have a Facebook page called the Bratt Office, which is a professional page, and which you can go and read the over 150 articles now that I've written about COVID, going back to the original article when I said that everybody is going to get COVID, everybody is going to get antibodies, natural antibodies, and COVID is not going to go away, and we're going to have to live with it, regardless of what the Chinese and the New Zealanders and the Australians try to do. The Australians and the New Zealanders have now given up on that. It's only the Chinese who are still trying to pretend that they don't have COVID, and it's beginning to ruin the economy. Anyway, just to come back to the actual situation now. As Dr. Strisiver said, and Rajiv said, the new virus that took over, the variant to the coronavirus that we have now, which we call Omicron, really is a sort of maybe a godsend, if you want to get religious, because it is so much more contagious than the former variants that it took over and basically has eliminated the deadlier variants. Now, this is so been so effective now that Omicron, for all practical purposes, Omicron in children, and I'm going to refer specifically to children, but it probably is the same thing as adults. Omicron in children, in healthy children, is nothing but a bad cold. It is nothing but a flu. It's similar to the flu. It's similar to a cold. There is nothing to be afraid of with Omicron. If a child becomes COVID positive, there is really nothing to be afraid of. And if there's one thing that we need to get through at this town hall meeting is this fact. Omicron is now a bad cold. Now, the virus has surprised us a lot. It's quite possible, although unlikely, that it will make another variant, and that variant may be more deadly, and that might mean that we have to go back to the bad old days. But as of right now, that is not happening. The Omicron has been around since January, February, March, April, 4 months. And it hasn't changed as yet. Yes, as Dr. Strisiver said, there are some new variants to the Omicron in South Africa, but they also seem to be very much like the Omicron. They are very contagious, they're more contagious, but they are not as deadly. They are not killing as many people. This is the thing now that I think we have to start thinking of. It's not enough to have articles in the papers saying 300 cases of COVID were encountered yesterday in the country and 200 cases and so on. First of all, that data is totally inaccurate because it's not picking up the number of people who are doing COVID testing at home and who are not reporting their cases to the Ministry of Health. And secondarily, the fact, as I say, if you get COVID, so what? So what? It means nothing. It's a bad cold. And we have lived with cold all our life. As a matter of fact, 10 to 15% of the colds that we have been getting for years are caused by coronaviruses similar to the coronavirus, the novel coronavirus that causes COVID. And it looks then we're now going to have 5 coronaviruses, which are giving us the cold. What we have to be interested in is the number of hospitalizations and the number of cases going to the intensive care unit and the number of deaths. And as we all know, this has fallen dramatically in the last 3 months. So these are the things we should be looking at. Regarding death on children, if you want more figures, 11 children have died in this country from COVID. That is 11 children over a period of over 2 years. So we have about 400,000 children in this country. That's 800,000 children, and we have had 11 deaths. In the same period of time, we've had over 600 children dying of various other things. This is what we should be concerned about, not Omicron, not the present outbreak of COVID. We need to keep an eye on it. We need to be careful, but that's the reality of the situation. And we need to look at the reality of what is happening in the country.
Thanks, Sherwin. This is Kahal. The T is silent. So I'm here in the UK. It is just about 1 a.m. in the morning. I was in the UK with my family since the outbreak. We flew from Guyana to the UK because we could not return to Trinidad because of the locking down of the borders. When I came here to England, my son was immediately able to start school in September 2020, primary school, which he did. And because his mother was working in a primary care service, he was allowed to go to school when the children whose parents were not working in what was considered a primary care service, like in a hospital or an NGO or a public health related sector or an emergency sector. So the children of parents who worked in those services were never denied schooling. And that meant about half the class stayed home. for a period of maybe several weeks in 2020, several weeks in 2021. And for the most part, throughout the pandemic, all the children in UK schools attended school. And if they had positive symptoms, if they showed the symptoms of having COVID, they were to test and they were to stay home until those symptoms were gone, and they were then returned to school. And where that happened, the parents of the other children were informed so that they knew that somebody in the class had gone home positive and was presently isolating at home, right? So that was the general protocols. The most important thing in the UK is the continuity of the school system for the children. The children were always considered to be outside of the risk of the virus. It was the elderly, those were the people who in the UK were focused on. And in that regard, what I want to say is that when the Delta came around last year, my son did get Delta. He showed very limited symptoms to it. It never slowed him down from being naughty or anything like that. For myself and everybody, we all got Delta. We were grateful when we got COVID, to be honest, because sitting around and waiting for it was never, was never nice. And none of us in our family were prepared to get the vaccine for our own reasons. And that was because we were aware of the options that we had in front of us, including ivermectin, vitamin D, zinc, and vitamin C, which based on our research, we all collectively agreed that we would not vaccinate because of the experimental nature of the vaccines and because we weren't convinced that it was the right solution for us personally. So that said, and just to come to the present then, so we had the Delta last year, and then this year we got the Omicron. And the Omicron as well, I mean, even myself who was down for about 12 days with the Delta, I had very limited reaction to the Omicron. I presume I had some sort of immunity, but certainly when that came around, it had very limited impact on me. It had no impact on my son. We had both tested positive, and he went back to school a week later. I want to wrap up by saying this. During the whole of 2021, tens of thousands of people in London took to the streets. They were largely middle-class English people who were completely opposed to the vaccine mandates, and they had the government in check that they would not use any form of coercion against either adults or children to take the vaccine. Having said that, in the UK, the way the vaccine uptake happened was out of sheer fear and anxieties that were developed during the lockdown, as the vaccine was going to be the only solution to this problem. And so those people went out for their first and second vaccines. But certainly amongst the children, I can say absolutely, we received one letter from the Ministry of Health because they knew that a child resided here. My son is 8 years old, offering the vaccine to him. And I looked at the letter. I think I took pictures of it, sent it to Rajiv, and told him this is the extent of the government's effort in the UK to vaccinate children between 5 and 12 years old. In other words, there was a complete choice. The vaccine uptake amongst children under 10 has been negligible. I think 2 or 3% of the children in the UK in the last 2.5 months actually took the vaccine, 2 or 3%. So in the UK, we had a case of choice, of voluntary informed consent. And this is radically different, of course, to the situation in Trinidad, where all of us, including our children, have been placed under a regime of fear, anxiety, denial of education, and coercion to take the vaccine as a solution. This is outrageous, as the vaccine is targeting the spike protein of the original Wuhan virus, and the virus has long mutated and is, as the doctors have said, is in its weakest form presently, is a natural vaccine, and everybody should welcome getting it now so we get over this. But there should be no more denial of the right to education. There should be no more anxiety, gaslighting in the population in Trinidad and Tobago. Most of the world has moved beyond this now. And I would say that this is the reason why CTAG has taken the legal action that we did through the Freedom of Information Act and the courts, and that we are presently preparing to challenge the government's vaccination program, as that it has no merit. It is not based on anything, that they're continuing to force the situation in children. So thank you very much, and I look forward to the continued discussion. Thank you.
So treat them the same way you would treat any child with the cold or with the flu. There's no need for anything special. There is nothing special. So that basically means that you keep the child home, as you would normally do. You keep the child and you treat the symptoms of the child. If the child is febrile, has fever, then you keep the child in a nice, cool room. Keep the child in a vest and a short pants so that his skin can breathe and he can get rid of the temperature. Lots of fluids, water especially, or freshly juiced juices, and then use whatever anti-fever medication you use, paracetamol or ibuprofen in the appropriate amounts, and you watch the child for complications. If the main problem is cough, runny nose, cough, sore throat, then you do basically the same thing. You steam the child, you give the child honey and lime, you keep the child, if possible, out of the air conditioning, because air conditioning is bad. It dries out the throat, it dries out the mucus, it causes the throat to itch, it causes the child to cough more. Although you can use an air conditioning if you want, but then you need a humidifier, because steam, warm steam from the humidifier is really what you want. If you don't have that, then you do the old time thing. You take the child into the bathroom and you turn on the hot water and you sit down there with the child 10-15 minutes. The child breathes in the steam, or you boil a basin of water, you put a blanket over the child's head, sit the child down in your lap. All of these old time things. You want to give the child some orange peel tea, you want to give the child some Chinese tea, green tea. All of these things are good. Comfort, hugging the child, making sure the child is reassured and has confidence that everything is going all right. And you look for worsening signs. The fever that is persisting after 3 days. We know with children, most fevers last 3 days, 72 hours, no more, and then they go away. Cough that is getting worse. The child starts to vomit. The child gets diarrhea, the child gets severe abdominal pain. These are all worsening signs, which mean that you have to check your doctor out at your health center, or take the child to the hospital. So it's the same old thing that you have to do. There is nothing special about treating children right now who have COVID. And in fact, there never really was any difference between treating a child who had the Delta variant as opposed to a child who has the Omicron variant. The children who are a bit sicker with the Delta, they're not as sick right now. And that's basically it. Well, yes. Well, first of all, it makes it easier for the child to breathe, because it hydrates the mucous membranes. It makes it softer. It warms the back of the throat, it warms the nose, it warms the back of the throat, it makes the little cilia work better. So it of itself, it eases up the cough. Because one of the problems with the cough is that sore throat, that dry throat, that itchy throat. Steam tends to help that. Now remember, it's not a panacea. It can't cure everything. It will not make the cough go away. The child is going to continue to cough, but he'll get relief from warmth. Rub the neck with Vicks if you want. Old time people would tie a scarf around the child's neck. All of these are attempts to warm up the upper airway so that the child can breathe better and the cough subsides a bit. I don't know of any studies that say that it helps, but look, if this is a good old-time West Indian custom that people like to do, it doesn't do any harm. It may help more than the steam alone, but the steam is fundamental. You can't use the Vicks and so on without the steam, I think. You need to use the steam with the Vicks.
Sherwin, so there are some very, very important questions being raised on the chat. One particular question raised the point that a child could contract Omicron at school and take it home for the family. And because Omicron is more contagious than the prior variants, then you can have a whole household that is sickened. Now, historically, children are not major spreaders of the disease. They are not major spreaders. But Omicron is quite novel. And I think that a child is able to transmit Omicron more readily than Delta or the Gamma variant. Usually the child will get better within about 3 days or so. So they may have a little fever, and they may have a little gastroenteritis as well, which is another facet of the disease. As I said, it seems to be changing a little. But the adult contacts can pick up Omicron. Now, and I wouldn't mind getting Dr. Strisiver's view on this as well. My experience with adults, Omicron in adults, is that generally it is a mild and tolerable disease. And as I said, it is not a virus that is causing major respiratory injury. It is not a virus that is causing major respiratory injury. And before I let Dr. Strisiver just give his opinion on that, the question is then, if COVID is here to stay and we don't have a vaccine that is actually stopping the spread reliably of the variant, do we lock up our children indefinitely from school? And I would like to talk about the UK experience a little later on in the session, right? But we must have face-to-face schools. So do we sacrifice our children's education because we fear our children infecting adult contacts? So how do we deal with adult contacts in Omicron? And is Omicron a major threat to adults? And I say, not really, not from my experience and not from the international data. I invite any other doctor to comment on that. What is Omicron like in adults? Yeah.
I think we're waiting for Dr. Strisiver to come in here.
I think he may be muted. Can we allow him to unmute?
Well, while we are waiting for that, let me just take you up, Rajiv, a little bit on your comment that children are taking the virus home. So it's very possible that this is happening more now with the Omicron. But it's not the major way that old people are getting Omicron. People are giving Omicron to the children. It's not the children giving Omicron to the children. Now, of course, this happens. I'm not saying it doesn't happen, but I don't think people should be too scared that they're going to get Omicron from their children to bringing it home. All the studies have shown, and we've known this since October 2020, that it's adults giving it to children and not children giving it to adults, and there are reasons for this. Omicron has changed, they say, because it's so contagious, it's changed the situation a bit. But the fact of the matter is, children at school, children are not responsible for this outbreaks, for the outbreak of that we are now seeing. And I want to at least give the Minister of Health some kudos for that. I think as of yesterday, he made that statement. It's not the schools that is causing the rise. It is the adults fetting, it's the adults in the bars, it's the adults in the restaurants, it's the adults in the gyms, it's the adult in the churches, it's the adults in closed spaces that are causing the problem, not the children. Let's please, somebody has to stand up and defend the children. So I give my little bit on that. Thank you.
Mr. Francis. Yeah, Dr. Labastide.
I just want to remind everybody that we do have immunity, natural immunity. We behave as if there is no such thing as an immune system. If we take good care of our immune systems, they can bring us through almost anything, right? And it's not perfect. It doesn't make us oblivious to everything that's there, but we have survived as a species because of the sophistication and the robust attention that this system gives to our environment and helping us survive in it. Some recent studies have begun to show that in the original SARS virus, way back in 2002, right, 20 years ago, people who had that still have antibodies that are protecting them from new variants of this SARS-CoV-2. People are asking, how long does natural immunity last? Natural immunity lasts as long as there is something to keep stimulating it. And as long as you have new coronaviruses, there will be enough crossover between those antibodies to re-stimulate the immune system and continue to protect you. It's natural boosting, right? And we are responding as a body to the entire viral particle, not just parts of it that begin to change and then make the vaccine or whatever you're using, whatever you're calling it, irrelevant. The body is responding to the entire thing. So a few changes in a new variant would not be enough to completely obliterate your natural immunity. And so you have some protection while the body mounts a response against the parts of this thing that are new. So we really should be focusing on taking care of our immune systems. Many of the older people have challenges because we have subjected ourselves throughout our lives to so many things, dietary and environmental, that are actually stressing out our immune system and making it less robust. and that's, to me, the major problem. We have to continue to take care of our immune system if we have to get through this.
Dr. Strisiver would like to be unmuted.
Thanks there, Rajiv. It's been a while since you asked me to make a statement, and I might have forgotten. I think what I wanted to say is that we have to get back exercising again. You know, I don't know why that was, an imposition was placed on that, because it's one of the most beneficial human activities that there is, especially families to go and walk around a field and whatnot. So people have put on weight, it's unhealthy. We got depressed sitting down doing nothing. We have to encourage, even in our offices, we have to encourage people to start the level of activity again. I now remember the question you asked, have I seen anything in my office different, say, since Omicron is on the scene? I'm not seeing sick people anymore, you know, even adults. And it's very heartening, of course. I haven't sent anyone to the government sector. People are just doing very, very well.
You know, it's a funny thing, doctor. I am actually seeing many cases now, but none are really sick. I mean, I'm testing more frequently now. Entire families are coming in and they all have a very, very mild course, just a little mild fever, and they're getting over. I don't know. As I said, they're not going, and I concur with you, they're not going to hospital. I'm not getting any person with any significant finding in the lungs, any lung failure or damage. Not even severe dehydration I'm getting.
Yeah, absolutely. Absolutely. I think one thing we had wanted to talk about also, I've had a child in my office who's had a severe allergic reaction right around the nostril and the mouth from his mask. Asking him further about his class, they have to sit at the desk all day. They have lunch at their desk, they get up, they're allowed to go to the bathroom and come back. And that is their daily activity. I mean, that must be a torment to any child.
Dr. Strisiver, can you all hear me? This is Kahal in the
Yes.
UK. I just wanted to say that I forgot to mention that at no time in the pandemic were the children expected to wear masks in school. At no time in the pandemic were the children expected to wear masks in school. A minority of children's parents chose that they did, a very small minority, but certainly that was not expected. And I can imagine in the tropics where the temperatures are high, that this in fact would be an obstacle to learning or any meaningful uptake and transfer of education. Thanks.
Yeah, definitely. From 2 years old, they expect children to wear a mask.
Sherwin, if I may, the conversation is quite exciting. We're heading into one of the latter topics. But if I may read from the contingency framework, education and childcare settings in the United Kingdom. This is from the government of the UK. This is dated February 2022, and it is at the height of Omicron, right? At this time, the vaccination rate in children, in fact, to date, the vaccination rate in children 5 to 11 is about 3% or less. So actually, the UK population has rejected the vaccine for this particular age group. However, the mandate, though, from the government is that the children must not suffer any loss of face-to-face education. The most important imperative of life in a British child is face-to-face education throughout the pandemic. And this has been in both the Delta and the Omicron wave. If I could read about the mask protocol, according to the UK Government Department of Education, I'll say, quote, in England, face coverings are no longer required by law. In education and childcare settings, face coverings are not advised for pupils, staff, and visitors in communal areas or classrooms and teaching spaces. Now, this may come as a shock to our population. This may come as a shock to us. In England, just remember that England is one of the hardest hit countries in the world. To date, their current daily death rate in England is 300 persons a day. This is under Omicron. Of course, we fell, I think, we are about 3 or so. But they have stated as a policy that children should not wear face coverings. Right now, why is this happening? I'm not here to go through all of the evidence base for it, and I think that as a population we will have to gradually evolve to this understanding. But I'm just simply quoting from the current status quo. So I concur with Kahal. This has been their experience over the last 6 months or so. What they realized is that they consider Omicron to be principally transmitted by droplet. Certainly there is some aerosolized transmission, but the problem with children, which is the same problem with adults, is that you can't wear a mask all day. If for a mask to work and I wear a mask, it is a PPE for me. It is mandatory because I am seeing COVID patients. I wear a properly sealed N95 mask. Now, I cannot see how that is going to happen with children. You can't have a child wear a properly sealed N95 mask all day. They're going to fiddle with the mask. So give and take, right? Just by touching the mask alone, touching the environment, you're also introducing potential virus onto the face, right? So what we have seen, even in Finland, the latest data is coming out where they showed that they just had a study with age 10 to 12-year-olds. They had 2 cities in Finland, and they looked to see if the mask mandate in one city made any difference in outbreaks. And they realized mask mandate in children, that is 10 to 12 years. And what they found is that there was absolutely no impact. So I don't know if we are ready as a society to fully embrace this. We are still wearing masks outside when we play football and so on. But I think maybe we should be having a serious discussion about at least facilitating a mask break for our kids, and at least making sure that when they are outdoors, they are getting fresh air. I think the issue of ventilation is more important, and I'll yield to the other doctors on the panel. If ventilation, because ventilation is well documented in the UK guidelines, how can we ensure that the classrooms are adequately ventilated so that the viral load within the air is not high? And of course, just to adhere to basic sanitation. Any comments will be appreciated.
The issue of masks is a thorny one because there are ways to use a mask effectively, and the general public, it's really impractical for most people under daily circumstances to use masks in a way that is likely to be effective. Apart from which, particularly, well, the disposables as well as the cloth masks, the size of the pores in the mask compared to the droplets that are likely to spread a virus, it's quite, unlikely that the masks are likely to protect effectively. As well as when someone exhales, the air is pushed out through the back of the mask to the back of the head. So you're actually spreading whatever it is. Now, a mask in the first few minutes when it's dry may provide some protection, but once it becomes moist, then there's nothing to prevent things coming through with the moisture coming through with whatever particles. So it's very difficult in our environment to use a mask effectively in a way that is likely to prevent any transmission either way from taking place. So the challenge with masks is that I'm not sure that it is practical for the general public and particularly children to use them in a way that it is likely to help. It is more likely that in our scenarios, we can use masks in a way that are likely to cause harm because they accumulate bacteria and so on and allow us to rebreathe the accumulated bacteria, and that could cause problems for people as well. So that's an entirely different discussion, but there's a lot of work going on right now about the effectiveness of masks, and there are some pitfalls that we have to be careful about. If we are not careful, we could do more harm than good with masks.
Yeah. Chauvin, yeah, I was just looking at a question here, some comments. I'm trying my best to respond. So yeah. Yes, please. Yes.
Yeah. Okay, hold on. Are you all hearing me?
Yes, we are.
Yes.
Okay, so just good evening to everyone. If you're just joining us on Zoom, YouTube, or Twitch, just a reminder that this is being hosted by the COVID-19 Transparency Advocacy Group of Trinidad and Tobago. And our panel tonight are frontline medical practitioners and an immunologist. And what is different and important here is that a lot of the people speaking to us, let's say from the Ministry of Health side, or let's just say contributors in the media, are not frontline practitioners. These people do not see COVID patients. In fact, we have information that many private practitioners outright refused to treat COVID patients. So it's important to understand this evening that the professionals that we have here, they treat COVID on a daily basis. They've got experience, and they've got 2 years of experience with it, on top of which they're well read. Additionally, we have Dr. Labastide, who is an immunologist, and he's going to bring a different dimension to that. Let us say the supporting data as to spread, and of course, as you just talked about, the mask. So I know a lot, I'm reading the chat, a lot of people are concerned about, we're hearing this in the papers and that. I ask you tonight to ask yourself if any of the people in the papers are actually treating COVID, if they're actually seeing it up firsthand. And that's something that we need to remember. And that's it.
I had there's a question here that I think Dr. Bratt may help address. It's from a parent who has 3 kids under the age of 6 and 2, started preschool and primary school, and the eldest child has the eldest child has a history of bronchitis. How is COVID expected to affect this child if this child becomes infected?
Well, first of all, before I try to answer that question, let me thank Mrs. Maillard for her statements. One of the, I don't want to say annoying, but one of the interesting things about COVID is how everybody has become an expert in COVID now. Everybody has an opinion. Everybody knows all the keywords, follow the protocol, follow the science, the comorbidities, and so on and so forth. Without really, as Dr. Labastide has said, people don't know anything about the immune system, but everybody knows about antibodies now, which is what 1/5 of the immune system, and it of itself a very complicated subject. So thank you for that. Big up to us that we are the ones seeing the problem. I am seeing children with COVID. I've been seeing children with COVID for 2 years. I've seen a lot more in the last 3 months. It's true, as Omicron has become more contagious, but I'm not seeing seriously ill children, and the figures in Trinidad and Tobago point to that. We just simply not seeing this. Now, this is really not the proper stage to answer personal questions, Dr. Seereeram, about what do you do with a child who has bronchitis? First of all, because I don't know if the child has bronchitis. The parents think the child has bronchitis. The parents may have been told by a doctor that the child has bronchitis. That doesn't mean that I would agree that the child has bronchitis. Maybe the child has cystic fibrosis. Maybe the child has bronchiectasis. Maybe the child has bronchial asthma. Maybe the child has a postnasal drip that stimulates bronchial spasm. All of these are different entities which in Trinidad and Tobago, people call bronchitis. So it's very difficult to answer that question. However, I will say in general, any child who has a chronic disease, which means the child suffers from it 3, 4, 5, 6, 7 times a year, once a month or whatever, those children are obviously at higher risk for a respiratory virus, which goes down into the lungs. Now, we do know that Omicron doesn't do that as much as Delta does. So the risk of something happening to that child is much less. And personally, I haven't had any problems with my patients who have chronic respiratory problems and the COVID virus. They all seem to get sick and they cough and they get a little fever for a couple of days, and then by the 3rd day, the children are back to normal. So I don't think that is a problem. Now, again, we're talking about a disease, bronchitis. Is it mild? Is it moderate? Is it severe? These are all, the child with severe bronchitis or severe asthma or severe cancer, or it's a totally different thing to a child with mild bronchitis, not mild cancer. We leave that out. So it's a difficult question to answer. And this is why at a town hall meeting, one cannot answer a question and give any sort of advice beyond the general reassurance that, yes, they do have to be a little more careful. They may want to consider was he talking about vaccines? They may want to consider giving that child the vaccines. I personally am not in favor of vaccines for any child under the age of 12. Definitely that it be mandatory. That's off the books at all. But there will be situations in which some parents want to have their child vaccinated, and they need to talk to their health advisor about that. And there are other situations in which children with chronic disease, leukemia, sickle cell disease, kidney problems, neurological problems, heart problems, those parents should think about vaccinating their child and discuss it with a health practitioner.
Thanks, Dr. Bratt. Yeah. Right. Sherwin, did we finish did we address all the issues that we
Well, with viruses in children, there really are no studies saying that giving these artificial supplements, by the way, everybody seems to be against artificial things until it comes to vitamins, and then everybody wants to pump their children with these artificial things. If you're interested in giving your child vitamin C or vitamin D, there are two simple things you have to do. Give the child a lot of mango, pomerac, guava, West Indian cherry, orange, grapefruit to suck and drink, and you'll get all the vitamin C that and more that it needs. And if you're interested in vitamin D, take the child out into the sun. So I don't hold with, now, if you want to, the question is, are these things good for children? Yes, up to a point, all vitamins are good. Are they especially needed when children are sick or when they have COVID-B? Not really. It's the same general advice that you give. I always advise the parents with a child who has a cold or a flu, don't keep the child in a room locked down. Take the child out, let the child breathe some fresh air, clean air, as much as it's possible to get in Trinidad with all the Sahara dust and the pollution from the traffic that we have. But take the child out, let the child breathe some clean air, stay a little bit in the breeze, cover up the child with a nice vest if you want. Let the child take some nice sun in the morning, early morning sun, 7, 8 o'clock in the evening, 4, 5, 6 o'clock. All of that is good. It not only helps the child, I'm positive that helps the child, whether it's the vitamin D or the mere fact that you're changing the child's environment and you are with the child, helping to support and encouraging the child. All of these are good things that we don't need research to talk about. So yes, they should be done, but I don't think that children need to be given these little syrups and tonics and so on. I think that's a waste of time and a waste of people's money. Absolutely terrible idea. It was, now you're really going to get me upset. Listen, keeping the advice that the ministry keeps saying was to keep your child indoors. That's the worst advice you can give to anybody when it comes to COVID, particularly children. Keeping the child indoors is where you catch COVID. Outdoors is 20 times safer than COVID. The studies have shown this. So we all needed to be outdoors. We all needed to be outdoors without masks. This virus is an airborne virus. When you're outdoors and breeze is blowing and there's hot sun and you are naturally, I'm not saying we're not talking about in a crowd for a Juve morning crowd or in tribe on Carnival Tuesday. I'm talking about the usual opportunity to go to a beach, not necessarily in Maracas. You go, if I went to a beach now, which I have done, I am trying to go to a beach that is not very well populated. There are some people, but there are people 20, 30, 40, 50 feet away from me. Salt water, child with a cold, the beach, salt water, hot sun, beautiful. That's what we should be making use of our natural attributes and not taking this lock up people. It's awful. It really is awful. And by the way, children shouldn't be wearing masks at all, as far as I'm concerned. Over the age of 12, maybe if they want to wear a mask. But the evidence is not very good. Yes. Well, first of all, number of cases rising rapidly. I would have to see the information. Every day I open the papers and I see headlines like COVID outbreak in school, and you read 5 or 6 paragraphs. And when you reach the end, they tell you 2 children in the school have COVID. I think the minister yesterday said that there have been something like 246 cases of COVID in school children in the last week, in something like 220 something schools, which works out to like 1.1 COVID case per school. So I really think that we should take a step back and look at the figures and see what is really happening. Now, for example, I have my grandchildren in Barbados. The Barbados Ministry of Education keeps a running tab of COVID cases, and they can tell you that before Easter, they had so many cases of COVID. And since Easter, they've had so many cases. And they can tell you cases are not rising. We have nothing like that in Trinidad. All we have is newspaper accounts with sub-editors who have these unbelievable headlines. COVID outbreak in a school. 2 children out of 580 children have COVID. And that is supposed to be a COVID outbreak. Give me a break. So what is your question, by the way, the initial question? My advice to the principal, first of all, we need to document whether or not there is really a rise. Secondarily, you need to sit down, sir, with somebody you respect, a medical doctor that you respect, and work out a protocol which is in line with the very complicated protocols that the Ministry of Education have for the management of COVID, and which seem to have a lot of people, the teachers I speak to and the parents, very confused about what to do. Do a child has COVID in a class? Do you close down the class? Do you close down the school? Do you send everybody home? Do you ask for a COVID test? Where should the COVID test be done? Can it be done as a home test? Do you trust the parent to give you a proper result? Do you have to go to a certified lab? Do you have to go to a public hospital or public health center? Do you need a doctor's clearance letter? All of these things really should have been worked out before we went to school. As far as those classrooms that are crowded, we've had 2 years to do something about it. I know private schools that knock down walls and now have one class in two rooms, whereas before there were 2 classes in 1 room. Why couldn't we have done this before? Why couldn't we have, Dr. Seereeram spoke about ventilation. Why couldn't we have done something about that? We know that ventilation is important. In classrooms, it reduces the risk. Many of our classrooms are overcrowded. Many of our classes have air conditioning. Air conditioning is I shouldn't say fatal. It's very bad for COVID transmittability. The virus lingers longer in enclosed, crowded places, as my colleague and fellow columnist, Dr. Joel Tilak Singh, has been saying for 2 years. Closed, crowded, closed places. Stay away from them. Why aren't we doing things like have been done in Europe, where they have what they call forest schools? So they have classrooms on the outside. Trinidad is a tropical country. Why don't we have, if the classrooms are crowded, can't we move some of the children out? I don't know if this is possible. It may be possible. It may not be possible. Keep windows open. Why aren't we talking about the filtering units that are used on planes and that are being used in the States, in universities, that trap the virus? Why isn't some of our money being spent in these things? Why wasn't all of this done? We've been talking about this. We've been talking about this for about 2 years. You know, this is nothing new. This is probably the first time it's on radio, but that's Dr. the sort of I would have.
No, the responsible parents group had sent some suggestions, protocol suggestions to the ministry. Part of it had to do with cohorting and ventilation. It was really impossible, logistically impossible, to keep children 6 feet apart. That's not possible at all, and it's not healthy either, because children need to socialize. I think with Omicron becoming the dominant strain now, we have to have realistic expectations. What are really our objectives? Is it to stop or to prevent Omicron from entering the school? Is that a realistic objective? Well, the answer is absolutely not.
Yes.
Every single school is going to get Omicron. The objective really is to just slow the spread. You can't stop it. You have to expect that every classroom will have a patient or a child with Omicron. Recently, I was aghast to read in a I think it's a Vedic school, there was a child who developed Omicron and they closed the class down. Now, I can't see the rationale for that. If you were to test, there's an observation in the comments here that the cases are underreported. I agree with that statement. The cases are vastly underreported. And notice, even though the cases are underreported, the deaths are extremely low. In children, in all variants, including Omicron, the deaths have always been nearly or minimal. I would say minimal if I choose my words clearly, right? As I said, there's no pediatric COVID-19 emergency. Internationally, every year from other pneumonias, there's about 1.5 million deaths in other pneumonias every year, 500,000 gastroenteritis deaths every year in children. For the entire COVID-19 outbreak since 2020, there are about 15,000 deaths in children. COVID-19 is not a significant threat to children internationally, and no complication of COVID-19 is a threat to children. Now, if it were that in England, the latest data is showing that 85% of the children actually got COVID, so that there is widespread natural immunity, that the children are actually a repository of natural immunity, herd immunity, then that is a good outcome. And it is an outcome that we should seek to in a safe manner. And the schools are also part of that. The question is, how do we respond when there is a child detected with COVID in the classroom? And I want you to know that only a fraction of the children will actually be detected with COVID, because testing is optional. You cannot force a swab into a child. The parent has to choose testing, right? So many children may actually have COVID and you won't detect it. The question is if the school administration is going to respond to a diagnosis of COVID with hysterics, close down the classroom. Now in England and in the United States, when a child is tested with COVID, they recommend that the contacts are not tested unless they actually manifest symptoms. In fact, another question in the chat was, why are children being kept home for 10 days? I don't know. It is because we don't have any proper protocols in this country. The children in the UK are kept home for 3 days. And once their symptoms have resolved, they are sent back into the classroom. So if you have a positive antigen test in the UK, what they call a lateral flow test in the UK, you have 3 days at home. Are you feeling better after those 3 days? Back out. That's how it's being managed in the UK. That's how it's being managed in many places in the United States. But in Trinidad and Tobago, what we're seeing here is a lot of hysteria in the press and in the media, and it is irresponsible. The objective of responsible purveyors of education, I would say Ministry of Education internationally, is to make sure that no child loses one unnecessary day of face-to-face schooling, because loss of schooling is devastating to the child, and especially cumulatively. And we can get into a discussion on chronic toxic stress if we have a little time this evening. But this is what has happened in Trinidad and Tobago. We have locked down our schools for 25 months. This is unacceptable. It is absolutely unacceptable. We need to make sure that for each child and each classroom, we do everything possible to make sure that they get back out into the school as soon as possible. And they do not miss school, because we don't have a facility for mixed schooling in this country. I don't think that many schools have that facility to have remote learning, blended learning, where you have in the classroom and remote, right? So, sorry, those are my positions I'm just stating. Any other comments? Sorry, yeah, Dr. Strisiver, is he on
Unmuted?
Yeah, yes, he's unmuted.
Right. Been muted for quite a while now, but I think it is difficult to approach the different stakeholders when there is no consensus, when there is no proper direction from the authorities. Whatever we may think ourselves, as David said earlier, we don't have a professional body that has stood up and offered a reasonable discourse on the way forward. It's like us crying in the wind that please let us take care of the children. Nobody seems to be looking at that. I saw that same thing in the news, Rajiv, in the Vedic school. One child gets COVID and the whole class gets sent home. So what happens if they come out in 10 days and another child gets it? They're back. So nobody goes to school. Nobody goes to school. We have not even got close to a solution. And also what I think I am seeing is that every principal has so much leeway that there is no cohesive idea about what is going on. The parents are left, as far as I'm concerned, they're left in the dark. Hence the fear, frustration. You know, I have patients who are saying, oh, the 7-year-old son, they're going to get the Pfizer as soon as it's available. You know, it was the mother telling me, I was seeing the mother, not the child wasn't there. But I didn't think I was the person there to start talking about the pros and cons of vaccination, that she's doing her son a disservice by making him think that the vaccine will prevent him ever getting this COVID illness again. So I don't know, David, Rajiv, Wayne, if we can make a petition to the various medical associations, North, Central, South, and see if they can come up with a unified statement, as late as it may be. Let them, produce something. What do you think, David?
Well, while we wait for them to consider our appeal and while we wait for them to deliberate, I just want to put this idea out there. COVID is with us and is going to be with us for the rest of our lives, the next 100, 200, 300 years. This business of sending children home because one child has COVID in the classroom, how long are we, and closing down the classroom or keeping the secondary contacts home? How long are we going to do this? How long are we going to continue to quarantine children unnecessarily for the 10 days as presently is being asked, being requested, when we know other countries are saying 3 to 5 days and you're back in school? How long are we going to keep asking parents to take their child to a doctor to get clearance? This is something that's the last month has come up every day. I'm being asked to see a child who's perfectly healthy, and they come in to see me and they're perfectly healthy. The parents have to spend money to bring them in to see me for me to write a letter to say that they're healthy so they can return. How long is this going to continue? Until when? I hear people saying until September, when things are going to get better. Things are not going to get better in September. It's going to be the same old problem. Hopefully, it will be the same Omicron and it won't be a new, deadlier variant. You always have to keep that at the back of your mind with this curious virus. So are we going to live like this for the rest of our lives? That every time a child gets a runny nose or coughs in the classroom, the child is escorted. There is one school that the child has to be escorted out of the classroom by somebody, a security agent, I suppose, and put in a quarantine room until the parent is called from their work. We're disrupting people at work to come and pick up the child, for them to now go and try to get somebody to, this is madness. We have to come to terms with that. COVID is nothing right now but a bad cold, and deal with it the way we used to deal with bad colds in the past. End of story.
Yeah.
Well, I wanted to just, before I refer to the question asked by one of our participants, I just want to say to all of us here you know, pre-COVID, Trinidad and Tobago, we always had a virus. You meet your friend, no girl, I couldn't read because I had the virus, right? And we, as Dr. Bratt is saying, this is no more than a bad cold. Well, we're used to that. We used to name our colds in Trinidad and Tobago. So we've obviously, I think, been inundated with a lot of information that we don't quite understand and that has made us fearful. So we need to think about that. We are adept at dealing with viruses. We name viruses.
Yes.
And if we're dealing with a variant that is no more potent than a bad cold, then why are we still so fearful? But let me get to the comment and the question by one of our participants. He said, the speaker suggesting that we only use natural immunity and not vaccination. With a virus that has a 3% mortality rate, would that mean we accept having 42,000 dying from COVID? Now, I hope the participant is still here, but it seems that he completely didn't get what Dr. Bratt just said. So maybe all of you all could just contribute to this.
I wanted to correct that misinformation, Deborah.
Right,
Actually,
but I found the mortality rate high.
Yeah, it's totally wrong. The survival rate in children, and let me make this clear, it's not just Omicron, all of COVID is 99.98% survival rate. Overall, the only children that have a fatal outcome with COVID are children with very severe comorbidities that maybe had some impact on their lung function before or some other system. Generally speaking, COVID-19 I would say children universally recover from COVID-19, all variants, including Omicron, Delta, Gamma, all. So I wanted to address that it's not a 3% mortality rate. The person in the chat stated a 3% mortality rate. This is absolutely erroneous. The mortality rate, the survival rate, or the mortality rate is 0.02%, right? Or 99.98% survival rate.
I have some data on that. If I'm allowed to share my screen, I could just put it up just quite briefly.
Sherwin, could we allow?
Okay, well, I have it open in a PowerPoint. So how do I share it with you? Because it says the host has disabled participant screen sharing. So I'm not sure how to do that.
Hello, can you all hear me? All right, while we're waiting, Dr. Seereeram, the same participant has said he's not speaking only about children. The 3% is a population statistic. I guess he's saying that the 3% is a population, complete population figure. However, this I think is tied to a recurring theme in the chat, which is, and we hear this in the media all the time. We've been literally bombarded with it, that your kid is going to get Omicron in school. Sure, the kid is going to get over it because they have resilient and robust immune systems. And this is no more than a severe cold. But what about that child taking it home to an elderly person who may be a relative or someone who is immunocompromised? That person may not fare as well with Omicron. It could prove, or can it prove fatal? So I think that even though I know this was addressed previously, we still have a lot of doubts, and it's because of what's been put in the media repeatedly, that the kids are going to take it home to the elderly and the immunocompromised, and they are not going to react as well as kids, and they're at risk. So can we go over this one more time?
You see, the question is, right, under what conditions? First of all, if we could at least agree, if we have a consensus that COVID is not going away at all, it is going to become, people say it's like the common cold. I would say it's the new common cold, right? COVID is the new common cold. It's more contagious than the common cold. So it's basically knocked out most of the other viruses. I mean, the other viruses haven't disappeared, but it's just become the dominant virus, right? So it's not going away. The question is, when is it safe to send our children back out to school? If we know that overall the death rate in Omicron is very, very manageable, it's 1/10 that of Delta. So, and we're talking about adults. Let me make it clear. The death rate in Omicron in adults is very, very manageable. It's quite low. The vast majority of adults are going to get over Omicron very well, right? We have seen it in South Africa. We've seen it in countries that have high levels of natural immunity, like South Africa, the whole of Africa. Even if you look at Jamaica with a 22% vaccination rate, Omicron has been very mild. Even in Trinidad and Tobago, Omicron has been mild. We know that it is not a threat to children. So what specifically are these questions? What are they insinuating the solution is then? Is it that we keep the children home? What are the conditions by which the children should be allowed to live a normal childhood and to have a healthy experience in school? What are the suggested conditions? Because I'm suggesting that we have met those conditions right now. We can get back our children out to school right now. It's safe. That's what I'm suggesting. Yeah. If they can put their solutions in the chat, what are the conditions that will make them feel better to allow their children back out to school as normal, right? Bearing in mind in the UK, the children are back out, the 5 to 11s are back out, they haven't taken the vaccine for whatever reasons, right? We're not really discussing vaccine too much at this time, but they haven't taken the vaccine, the death rates are extremely low, they're not even wearing masks in the UK. From the UK government policy, they're not even wearing the mask. So they have done it, and their children are experiencing good, high quality education. And we can, if we have some chance within this chat this evening, we can discuss how dangerous this withdrawal of face-to-face schooling has been. It's been devastating to the childhood development, to the children's development. We may get to that point. I'd like to let Dr. Labastide make his point.
Yeah, I just wanted to reinforce the point that you can see these are US figures, of course, because they're readily available, showing that even the people who are most vulnerable, likely to have adverse outcomes, when you get into the 65 to 74 age group, you're still talking about a 95.6% recovery rate, right? There clearly is no emergency in the children because we have a 99.98% recovery rate. That kind of rate continues up until you get into the upper age groups here. Now, we also need to remember that even though these people up here are more likely to have complications and significant debilitating outcomes, we have treatments that work. We are speaking as if there is no such thing as a treatment that works. We do have treatments that work. Some of them are ignored and some of them are censored and so on, but there has been a lot of evidence of workable treatments. So this is not a guaranteed death rate here. We have to become a lot more pragmatic about how we deal with this. There's no point in assuming that this is a death sentence here. We have interventions that work. And the risk, the absolute risk here is still relatively low, considering all the other things that are contributing to the sickness and death of people in these age groups.
Can I just add in something here? We're not exactly what you're saying, although this is a beautiful slide. I hope people have enough time to look at it and understand it. But to go back to what Dr. Seereeram was saying, and I want to ask Mr. Kahal if he's still awake and still with us. What has the experience been in the UK with children taking the virus home and giving it to the elderly family? Because as far as I know, this has not been a problem. So this is a question that every time I speak to a teacher or parent, they do bring this question up. So it's an important question that we need to clear up. Are the children taking the virus home, giving it to elderly parents, and the elderly parents are then dying? That is what everybody it seems to be most scared of. The first thing is that COVID is somehow dangerous to children, which it is not. But the other important thing is, and some teachers are upset about this too, because they think that they may get the virus from the children. So, and the experience all over the world says this, and this is real experience. This is people who have studied, that slide shows, hundreds of thousands of cases. And this is not what is being seen, but I don't know. Maybe Mr. Kahal, if he's wrong, to give us his personal experience.
Yeah, David. So the experience of our family here was that indeed last October 2021, my son, an 8-year-old boy, he did bring the Delta virus home. We all tested positive for it.
Please hold
And
for a second.
I
Kahal,
think
just hold for 1
remove
second.
the
Just
sharing to
please
participants
mute
using it.
Antonio Brown's screen. Please remove Antonio Brown. Showing. Thank you.
yeah,
Kahal?
sorry. Yeah, sorry, Dr. Bratt. So I was saying, yes, my 8-year-old son did indeed bring the Delta virus home last October from school. He tested positive, and everybody in the house tested positive. That included my 84-year-old mother, my sister, who's a little older than me, myself, the wife, and of course my son. But what happened with us, as I mentioned before, is that we were sort of prepared for it and, in a sense, looking forward to it, which I think was a little bit different, despite the fact that none of us had been vaccinated. We were on a course of ivermectin, which we upgraded, and I believe, was effective in minimizing the impact of the virus on us. So that indeed it was through him that it came home, we believe. And then in this year, in March, he came home again. He was in school continuously, came home with COVID Omicron. It was confirmed in myself and him. It was never confirmed in the others in the house, as nobody else was symptomatic. He had no symptom with the COVID, so he was asymptomatic with Omicron, and I had a relatively mild experience of a common cold, which was radically different to how we had experienced the Delta, where I think the adults in the house were definitely showed flu-like symptoms. I perhaps was the worst symptomatically than everybody else, and it lasted longer in me, about 12 days, where I didn't feel well. But my mother and my sister and my wife were relatively unscathed by the Delta. So that's what I'd say, Dr. Bratt, that indeed it did come through our son, and that's what we all believed, and that's how we were affected.
Thank you.
Little point here. Reggie, you gave us the statistic just now of the mortality in children of 0.02%. And earlier today, I looked at how many children in the United States died due to COVID. The grouping children starts from 0 to 18 in this particular statistic. There were 416 deaths of children in the United States. The total number of children in the United States is 74 million. 74 million, and you have 416 deaths. Now, the death of anyone, and any child particularly, is an overwhelming loss. But I think when one looks at figures like that, one sees that this is not, a disaster for mankind. And we have to look at it. Yes, a child may bring home the virus. Yes, there may be somebody immunocompromised at home. Someone tell me what the solution is, because I don't see the solution. Child has to go to school. The person may have had a transplant, a renal transplant. They're on immunosuppressants. They certainly don't want to get an unnecessary virus. They can practice all the hygiene at home, the person who's immunocompromised can wear a mask. The child, all the children, that would mean all the children coming home would have to wear masks. So rather than look at a solution that would include a whole sector of society together, children have to go to school, children have to come home from school. Let us find the solution to these sorts of problems in the home. That's my opinion when that sort of question is put to us.
You know, I once again, I wanted to repeat the point that there has never been a pediatric emergency for COVID-19. There's never been an emergency in children for COVID-19, but there is an emergency in our children right now. And I wanted us to understand there's quite a lot of studies on the mental health impacts of the lockdown on children. And I think we can see it before us. I know there is a saying in Trinidad, spare the rod, spoil the child. And there are some quarters of society that are calling for more punishments on our children that are misbehaving as they have returned to school. But really, as a society, we have really traumatized our children and punished our children. Just to give you a little dimension on what they may have faced, there is a plague of sexual violence on children, right? Mostly perpetrated by their own family members, Think about 25 months of lockdown. Notice that in Trinidad and Tobago, we have the longest lockdown of schools in the world. Thank God that we are open now. But I am saying this because I'm trying to dissuade any educators. I'm trying to dissuade any parents who think that locking their children back, locking them down again because we have Omicron is potentially a good idea. And I'm saying it's a very, very bad idea. But what I'm saying here is that a lot of children, they say sexual violence is up to 20% in many places. Maybe in Trinidad, it's even higher, right? And it's perpetrated by family members. But during the lockdown, what they have found is that children suffer from toxic stress. Toxic stress is the kind of stress caused by neglect, caused by anxiety over the neurosis surrounding COVID, caused by isolation, social isolation. And what it does, it causes problems with cognition, memory, even concentration. And we are seeing these problems. We're seeing problems in both male and female students. We're seeing conduct disorders. They're hitting out. There's a lot of violence, right? We are also seeing depression, anxiety, neurosis in children, even suicidal ideation. Think about the harm that we have done to our children. And in fact, our children never benefited, and there's no good evidence that closure of schools actually slows the spread anyway. There is no evidence of that. When the primary school, the Vedic primary school, sent home the class because they found one child in the class was diagnosed with COVID, you sent the whole class home for how long? Maybe a whole week. Think about the harm that is being dealt to the children. And are we prepared as a society to continue along this pathway? Or are we going to act with reason and responsibility towards our children? I'm just putting that out there. We can't really get into the psychological or the mental health impacts on the child. It's a conversation that's too deep. I know that we also wanted to have an open forum so that people can actually raise their hands and start and vocalize their questions. I don't know. I think Mr. Francis Sherwin, can we proceed to that segment? Please, Mr. Corbin, you are a very welcome guest. Thank you for being here, sir.
Thank you, Rajiv. It's a pleasure. It's a pleasure to be here this evening. Hello, everybody. It's fantastic to listen to reason, and it's fantastic to listen to voices that are actually understanding what is happening on the front line. And one of the core competencies of the education of about the whole COVID thing is that we have a severe problem across the Caribbean region where we have authorities who are speaking from positions of ignorance rather than from positions of educated knowledge. And this has completely devastated the ability of parents and students alike to get any kind of reasoning from the whole understanding of what the proper educational system should be. The most
Mr. Corbin, please hold for a minute there. Can we just remove this person, Mr. I think it's Sims, Johnny Sims, screen sharing. Go ahead, Mr. Corbin.
Sure. I think one of the most harmful things that the entire school system has adopted through ignorance, not through knowledge, through total ignorance, is masking of children. There is absolutely no excuse to put a mask on a child that has an immune system that is 7 times more robust than an adult. And one of the things that we must understand, not only about Omicron and all the rest of the variants, which are caused by vaccine injury, not that there's any specific mutation. Omicron and Delta are the result of vaccine injury. And it is absolutely important to understand that. We're not talking about a virus. There never has been a virus. There's been a biological weapon that mimics the symptoms of a viral infection. There has never been a virus. Omicron and Delta are both the result of vaccine injury, and they are not viruses. They are diseases. It's absolutely important for us to understand that. Everybody thinks that it's a virus because the CDC and the FDA and everybody, all the doctors are talking about virus transmission. Wrong. It is disease transmission through the shedding of spike proteins due to vaccine overpressure within the body. The immunogenic response of the body is shedding spike protein out of the skin, out of the sweat, bodily fluids, and it is contracted through touch. It is not airborne. It is a biological weapon that it is not able to be transmitted through the air. It is done by touch. You can have on a mask, you can wear all the surgical suits and the gloves you like. If you touch something that someone who has been expressing spike protein shedding due to viral overpressure, you will become infected. So this nonsense about putting on a mask and then you handle money to a cashier and then you sit at a table and you touch a glass and a bowl or something like that that has been touched by someone who is vaccinated and has experiencing or expressing viral pressure overload and shedding spike proteins, you will become infected.
Mr. Corbin, this conversation is very deep and there's a lot of contention surrounding the virus.
Anyway,
Could we just wanted to, we wanted to talk about the practicalities of education in Omicron. So, you know, I don't mind if we have the conversation in a smaller circle, but we have many educators here that are quite interested in finding some, you know, the way forward.
So here's a way forward. Here's one way forward. Here's one way forward. And this is very, very simple to do. Okay? Children are attracted to anything that tastes good. So let's look at a program like what we're doing in Jamaica right now, okay? Where we can make an immune booster drink that can be sold in schools. That's what we're doing in Jamaica right now. We're investigating that and we're putting it in place, and people are using an immune booster drink made of natural herbs and so on, which tastes good and everything. It's almost like a peanut punch, coconut punch, something, and we can put it into schools and sell it. Okay? Let's move that forward. Let's get the immune system of the children up to par. Then we can talk about going further. That's all I got to say. Have a good night, everybody.
Can I make a quick comment about getting the immune system back up to scratch? there are some things that we take for granted, and as much as we talk about building immunity and so on, there's a silent immunocompromiser that nobody's paying attention to, and that's sugar. Sugar is very toxic to the immune system. It suppresses immunity, but we put sugar in just about everything. We're giving the children in the drinks and the food, their cereals, everything, it's all sugar. Sugar is very toxic. It compromises the immune system, and a lot of us are sick because we are really immunocompromised and we don't even know, because a lot of our meals, our carbs and so on, have our sugar levels. If you look at diabetics, who are the extreme example, uncontrolled diabetics, who are the extreme example of the situation, they have trouble healing wounds, they have trouble resisting infections, because the sugar blocks certain mechanisms that are required by the immune system to function properly. So while we are talking about all the other things that we need to do and using natural vitamins, synthetic vitamins are a complete waste of time, natural source vitamins and so on, which are also very important to the immune system. We have to be aware of the ubiquitous sugar that is causing a lot of us to be sick, because our immune systems are compromised because there's too much sugar blocking processes that are required for immunity.
Hello, good evening. Yes, yes, hi, good evening, everybody. So it's been a very interesting talk. I'm very happy for the input from all the whole panel. I'm especially very happy to hear that Dr. Bratt said that he's definitely against mandatory vaccination of children on the age of 12. And my concern is that once Moderna or Pfizer gets approval from FDA and eventually WHO to vaccinate children, our government will probably follow, like many governments in the world, and follow suit. What WHO says is what we follow, very blindly. And that is what I'm afraid of, in the sense that a couple months ago, the Pfizer was trying to block the release of clinical data on the trials of the so-called vaccine. I don't call it vaccine at all. It's more technology. And they said, well, they couldn't release it. We need 55 years to release that data. Eventually, the federal court judge ruled that they had to release it. And lo and behold, there were 1,291 adverse effects of the Pfizer so-called vaccine, 55 of which are extremely serious and potentially dangerous. So my question is, as Dr. Bratt also said, that's quite right. We as a professional body, the Medical Association, with North, South, Central, it doesn't matter. The point is, no one has ever come out and speak to the public about COVID, how to handle COVID, they just say, look, you have COVID, just stay home, just take some vitamins and whatever, but nothing to really help them fight the COVID. So I believe that if and when the ministry tries to say, okay, the WHO has approved vaccinations of kids, we will follow suit. I think some medical organization must stand up against that, because as we've all said tonight, the risk of kids having severe COVID is 0.02%, and the risk of so-called vaccinations is far, far higher. We don't know what's going to happen, even the adults who've gotten it, or the teenagers who've gotten it to go to school, secondary school. You don't know what's going to happen a year, 2 years, 3 years from now. There's a possibility that we may have a whole big explosion of autoimmune disorders triggered off by these so-called vaccinations. And as Dr. Labastide, who I know quite well, has said, when we get it, to me, it's a combination of everything that everybody has said. To me, the Omicron is God's gift to mankind. And that's my personal opinion when it came out a few months ago. Because I felt that when you have immune system triggered off, it's going to form antibodies, the entire virus, all the proteins on the skin, the shell of the virus, 27, 20 of them or whatever, you can get pretty good overall protection among the majority of variants that may come down the road, as opposed to the immunization antibodies that are produced to the spike protein is very, very limited. And as Dr. Labastide said, it's IgG and not IgA. So it is very limited help. That's a major point I need to bring up. That if the Ministry of Health decides to insist on mandatory vaccinations of the kids through WHO guidelines, then I think we as an organization of doctors who are concerned about the welfare of our children and grandchildren, in my case, we as who know a lot of the facts, we must stand up against it. I want to stress again what Dr. Labastide said. The major thing for us adults or kids is to have an immune system. Yes, sugar is extremely bad for the immune system, but also processed foods. What's interesting is that I treated many cases of COVID, both Delta and Omicron. And in the Delta cases, I found that vitamin D3, C, and zinc were very helpful in helping patients overcome the Delta variant. And although we live in the tropics in Trinidad, where there's a lot of sunlight, I started doing routine screening of patients in my office for vitamin D levels. And I found every single one of them I sent for D levels. Unfortunately, it's a bit expensive, like $500 for a test. But almost every single patient I sent for D3 level were all very low, in the 30s usually. And the optimum level is where between 60 to 80 is the optimum level of vitamin D in the bloodstream to have a really immune system. So D3 is very effective as an immune system booster. It's very essential. And even in cases of coronary heart disease and cancer, we use D3 as a supplement to help the patients fight coronary artery disease and cancer. So, and I think the D3 deficiency is because of our lifestyle. Our lifestyle in Trinidad for the adults, luckily the kids are more in the sun, hopefully, than the adults. But the adults, they're in their homes, there's no sunlight, except a little secondary sunlight from the windows. You go into your car, no sunlight. Go into your office, no sunlight. At the end of the day, back into the car, again, straight into the house, hardly any sunlight. And so I have colleagues, I belong to an organization based in South Africa. And a couple of doctors I spoke to, they themselves checked their own levels of D3 and said they were also deficient and they were quite surprised. And it's because of our lifestyle. One more thing I would like to say is that when the adults are concerned, I know the emphasis tonight is on the kids. But where the emphasis I would like to make a point is that boosters for adults are totally unnecessary. The more boosters you give, the more you suppress your immune system. So I think our focus should be build an immune system that's very healthy, but healthy lifestyle. And there's nothing of emphasis on lifestyle changes. Yes, we have to follow all the natural obvious protocols of sanitization and all these things from the ministry. But just want to reiterate, we will have to fight the Ministry of Health if they want to introduce mandatory vaccinations to our children below the age of 12. That's my opinion. That's my input.
I just want to thank Dr. Seereeram for those of us here. Dr. Seereeram is a medical practitioner and he's also a homeopath. So he sort of practices on both sides. Yes, so we'd like to invite educators, persons working in the education sector, whether public or private, to please raise your hands, and the moderator, Sherwin, will take your questions. You can speak with the doctors and we want to encourage that. So please feel free to do so starting now. And I would like to address Siobhan Valentine, who's a participant here. Siobhan said that teachers have to send the diagram and the ministry decided who quarantines. I want to find out more about that. Is it that teachers now have to provide the ministry with a diagram of where COVID cases, where children were sitting when they got Omicron, and then you have to submit this and then they'll decide who in the class has to quarantine? We'd like to find out. So we're inviting educators, those involved in education, whether it's in the classroom or in administration, whether government or denominational, please raise your hand and speak with our team of professionals one-on-one.
Right, right, Ravi Ramdin here, right? And what I wanted to know is this, right? I have been listening to people like Dr. Paul Alexander, and I'm talking about researchers, not doctors, researchers, people who have used labs and went through this entire thing with vaccines and Delta, Omicron, you name it, they did it. And it was debunked quite a lot of times. And these are not the people that are regurgitating other things from other people. These are the real researchers that are out there. And the whole thing about it, right? If it is that in the beginning, when they started to do all the pertinent, yes. So if it is that a child was said that cannot be affected by or even transmit this thing that we call in a virus, right? Why it is that we want to vaccinate a child and there's something called shedding. So I want somebody to answer my question on that, because I'm sure it have a lot of people that want to ask these sort of questions, but this is a controlled environment. Thank you very much.
Kevin, if I can you hear me? Okay, now we were not having a specific discussion on vaccines. There's a lot of contention about pediatric vaccines. Our position has been that there is no good evidence, given that the vaccines in 5 to 12-year-olds, the efficacy against transmission falls to 12% in 2 months, okay? And that there's an unknown risk of myocarditis, which is now cropping up. We feel that the vaccine should only be administered with voluntary informed consent, meaning that those risks should be transparently disclosed to the parents, and that the parents should understand what the administrator's position is on liability. So if the vaccine carries with it some risk, if the risk is small, then the person who's administering the vaccine or the body that's administering the vaccine should have confidence in their product, and they will take liability for any potential injuries. That is the most that I could say about the vaccine right now. We know that many persons feel a bit anxious. Perhaps some people may think that if the vaccine comes into the primary school age group, then it would now be safe to go back out. But I asked you then to consider, if we know that the children have a very, very nominal risk of severe disease or deaths with Omicron, MIS-C is not a major problem with Omicron either. It's not a major problem. And let me reiterate that. I know there was a question about MIS-C in the chat. So if the children already have an excellent outcome, but the vaccine is not reliably stopping the child from contracting the virus or transmitting it, then the rationale for using this product in this age group is not very strong. And as with all medical products, individuals should have the option, families should have the option to choose or to refuse. And in fact, it is not the business of any institution beside your doctor to know your vaccination status. That should be your private and confidential medical information. Now, if you would like some of the data that I'm quoting, I'm talking about the New York data set. We know that internationally the vaccine efficacy is dropping very, very rapidly, particularly with Omicron. Some estimates are around 8% in 3 months. So 8% efficacy. So your chance of transmitting or contracting the virus is still 92%. And as I said, you're not really getting a significant gain in terms of morbidity or mortality for the children. So I think it is, we must support choice here. So if I can address that, the issue of the vaccine, but I think that there are some other issues, if any educators are present, and maybe they could share their stories about what they're encountering in schools. I know that there's a lot of anxiety over the logistics of managing COVID in the school, maybe questions about isolation in schools, questions about ventilation, if there are any questions specific to those things.
Hi, good night, everyone. Good night to all you doctors and listeners. I have well, one is a question, one is a statement, or to share an observation that's happened. I have had the experience of a lot of COVID passing through in my circles. I have children in all age groups of schooling, and I have found that the COVID does not come through all at once. So it'll come through. Some people are locking children in one room, and it's not spreading to the rest. Then you find some people are sitting with the children, sleeping with the children, so the whole family can get it at once. So different families have different risk factors and different beliefs on how they want to manage this. And I know families that have been quarantined for 6 weeks straight because one child got it. They quarantined the child, isolated the child, and then the one adult, and so it kept going for 6 weeks. So my question is, the main question is, how come it's not spreading right through everyone? And that will be in families that are all vaccinated, in families where some are vaccinated, some are not. I have the gamma of experiences from being around this and talking about it and researching it. So how come some people are just not getting it, whether vaccinated or not, in a family where they are all exposed? That's the main question. But the other thing I wanted to share is from a school point of view. My children who are in secondary school, they have had a rough journey last term when they were allowed to go out. And it was the fair again, and people were, you must quarantine, you must do this, you must do that. And in my family, my children were quarantined for about 6 weeks out of the 11-week school term. And there was no, backup system for them to learn. So we thought we were doing the right thing. The school thought they were doing the right thing. Everybody is fearful. And my children they actually learned more when they were online than when they now went back to school because of all these dramatic quarantining tools that were given to the schools to use from wherever the guidelines came from. And so what I'm saying now is that now the primary school children have just gone out. I'm sensing that we're heading in the same direction, but hopefully we will be smarter this time. I'm not saying that we must be irresponsible. Don't send your children to school if they're sick. But for these little ones now to be quarantining week after week after week, waiting, in my situation, the kids were quarantined for 6 weeks from different cases in the classroom. The whole family had COVID except one child. And that one child kept escaping COVID over and over for the last 2 years. And then ultimately in the 6th week of the quarantine over the school term, he ended up getting the COVID. He got it mild, he got Omicron, I'm assuming, and he had a sore throat and a little achy body for 4 days or 5 days. So for me, I don't want the same thing to happen for the secondary schools to the primary. And these kids are back and forth, home, and they end up missing out again on a full term of education. So that's my comment and question. Thank you.
I'll make a quick comment about the some people getting it and others not, even though they share the same household and so on. As with any infectious condition or even non-infectious conditions, everybody's immune system is in a different state. And whether something will manifest depends on the state of your immunity. So something would come through a household and some people would never even know that they came across the pathogen because their immune system dealt with it. They had no symptoms or minimal symptoms and they just pass over. And then there may be someone else in that very same family that got sick enough to be taken to hospital. It all depends on the state of your individual immunity. So there is no one pathway or one manifestation of either a communicable or non-communicable illness in any individual. We all vary depending on a combination of our genes and the things that we have done in our lifestyle that manifest in terms of how well equipped our immune system is to deal with the things that are thrown at us. So there's no one answer to that. You will get a variety of apparent responses and manifestations depending on what's happening with the person's immune system.
If I can provide a little insight from my observations, right? Let me see, I put this back on. I felt that COVID-19 triggers a sort of autoimmune or a kind of hypersensitivity response. So the lung injury that we were seeing happening with the Delta, Gamma, and the prior strains occurred because the virus had a predilection for the lung. So it was sticking around inside the lung, and it was triggering your own immune system to attack the virus. So your immune cells are migrating into the lung, trying to attack the virus, but then something goes disquanky, and there's an over-aggressive immune response, and that starts to cause damage to the lung. So it's your own immune system damaging your lung. Now, when it comes to pediatrics, the child's immune system is more naive. It's nascent. It's not as primed. And this is, and Dr. Labastide could probably give a little insight into what I'm saying as well. It's not as primed, so the child's immune system does not attack the virus in the same way that an adult's immune system would. And this is why you don't have this sort of overly aggressive damage to the lungs. I say it's like akin to allergy. A perfectly healthy person could have an allergy to peanuts. There's nothing wrong with the person. It's just that when they come in contact with the proteins on the peanuts, their immune system reacts to the peanuts in such a way that they could die from it, because it causes swelling in the throat, it causes swelling, and it can cause hypotension and shock and so on, right? So it's something similar like that in COVID. Some people don't react to the virus much, particularly children. They don't really react to the virus much. But when you look at age, there certainly is an age, there's a correlation between the person's age and their reaction to the virus, okay? And what you find is, I have found that it peaks somewhere around in the 60s or so. That's debatable, right? But certainly for children, because their immune system doesn't react to the virus as much, we don't get that kind of damage. So in households, what I've seen as well is in households, you will find some people, they have the virus in them if you test them, but their body is not reacting to it. So they don't get sick with it. Some people, I don't know if it has something to do with the ACE receptor, they seem somewhat immune to the virus. Maybe they have mucosal immunity. Maybe they just have a better innate immunity. They just have better barrier immune response in the mucosa. So they just resist the virus. And then some people, they could be a perfectly healthy person, but they just happen to be the ones that react to the virus, just like a healthy person reacting to shellfish or peanuts, and then getting a very bad course of the disease. That's how I see it, and that's my experience with it. I was reading a paper recently that was showing that the mucosal immunity in children is a little, it has more, it's a little more responsive. It could pick up, it can respond faster, it can mount an immune response faster. Is that true of children's immune system? Right. There's a question, sorry, as I wait for Wayne to unmute. I think everybody's muted, Sherwin. I have heard
Rajiv,
that.
are you hearing me?
Yes, I am.
Okay, so there's a really interesting question, and I'm hoping that the educators do come on in, but it seems that they would like to know how they should deal with it in schools. And I think a lot of the educators are looking for some sort of roadmap here tonight. But before you answer, I think that we must all consider that we're dealing with two sides of an issue here. Tonight, we're dealing with the medical side of the virus and maybe the management of it. But there's also the administrative side of the virus, which we can't get involved in. the educators really, we could tell you not to be fearful, but how are you going to treat with the Ministry of Health and the Ministry of Education's policy is going to be a matter for you all. What we're trying to do tonight is to inform you so that you could decide if that policy, if one does come forward, if it is practical, if it is doable, workable, and if it's not, are you prepared to present to the ministries what you think should happen in your establishment based on the environment that you're in? So I don't know if you could help with that, Rajiv, or Dr. Strisiver or Dr. Bratt. How should educators, administrators deal with what is going to be kids getting infected at school or testing positive? There's also another question there. You know, the PCR test is expensive. Can the rapid test do the job? Should the Ministry of Health or the Ministry of Education be supplying these rapid tests to the schools, or are they absolutely unnecessary and we should go with what we see? So I don't know if any of the doctors can speak to that.
Firstly, I think there's precedent internationally in the management of schools during COVID, right? We have seen clearly that schools have been operational in places like England and the United States and Sweden. Sweden never locked down their schools really. They closed their secondary schools for a while. Primary schools remained open. So there are many countries that have considerable experience and well-articulated protocols for continuing school during COVID. And they had much worse strains at the time. Right now, Omicron, as I said, it's a kitten compared to Delta. If a child tests positive in school, if a child is first of all, let's see how are we going to detect a child in school? Temperature testing. So we usually start with temperature testing at the door, right? It's not very good. What is happening is that usually if a parent is bringing a child with COVID incubating in this child's system, they're not going to bring them with an obvious temperature. And many times what's happening with Omicron, the incubation period is quite short compared to the other variants. So maybe in 2 days, the person, after exposure, maybe in 24 hours, you will find that the person is actually manifesting Omicron, symptoms of Omicron. Prior variants, particularly the Wuhan strain, you'd see that take maybe a whole week before somebody gets symptoms. So sometimes you have somebody coming in, they were exposed the night before, they felt well in the morning, they go to school, and then you have some vomiting or headache in the morning. So the child is caught at school with symptoms consistent with COVID, but they pass through they pass through the temperature monitor in the front, right? Because as I said, temperature monitoring, the evidence for that is very bad. But it gives people a sense of control, but it's not good at all, right? The virus has to actually be in a state of, you have to have viremia at the point for them to be running a temperature. And with COVID, the temperature comes and goes, right? So you are very likely, all educators are going to face COVID in their classrooms, right? If you have a child that has symptoms consistent with viral illness, it may not be COVID, it could be a common cold, it could be influenza, but you have a child consistent with viral illness, you should have an infirmary, right? Try to handle the child with a N95 mask, right? You wear N95 mask and call the parents. The parents will have to take the child home and they will have to test. Now, you can't force a parent to test a child. You can't force a parent to test a child. You could just advise him and said, look, for our information, please take the child down to the health center or go to a private practitioner and get a test done, right? The rapid antigen test is invaluable. There's a major problem here, once again, because we have not established that we should keep that the main objective is to reduce loss of schooling, loss of face-to-face schooling. So it would appear as if it's okay to send a child home waiting for a PCR test from the ministry for several days whilst they are losing time. That's not correct. We should have rapid antigen tests or rapid PCR if possible, but the antigen is quite accurate right now for COVID. It is relatively accurate. We should be able to have a lateral flow test or antigen test. The lateral flow is another term for antigen, right? You should be able to get that back within, it literally takes 2 minutes. It's easy to administer. In England, the homes, lateral flow tests were sent at home. So parents can actually do it and detect it early. We can't stop the spread of COVID in the school, but the objective is to slow the spread. You don't want a whole class full of COVID, right? Because you don't want a whole class full of febrile children and vomiting and so on. You still want to try to pick it up early before the child intermingles with everyone, right? The key for picking up early is 2 things. 1, a high degree of clinical suspicion. You must have teachers and parents well educated for the signs and symptoms of COVID. The signs and symptoms of COVID should clue you in whether or not your child is at risk of having COVID and thus transmitting it. The signs and symptoms of Omicron, frequently a headache, a little bit of vomiting, maybe a little diarrhea, maybe an abdominal pain. The child might get a fever within the day. Sometimes there's a respiratory tract illness as well. 50% is like respiratory tract, but cough comes later. Usually it's a fever starting early, right? So you as a parent and as a teacher, the most sensitive instrument you have to pick up COVID is not a thermometer at the gate. It's not even a rapid antigen test, which will come in later. It's your clinical suspicion. So you feel a child may have COVID, don't freak out, it's okay. Just take the child calmly, carry the child to the infirmary, make sure, first of all, most important is that the child must be well, right? You don't want a child who's sick and we're not attending to the child's needs. The child's needs always come first, right? So make sure you have Panadol on site so you must be able to take care of child, right? The child is in your care as an educator. You have to give the child some Panadol, make sure that the child is not in any pain. If the child is vomiting, also you can even give a little piece of gravel. You should have at least call a doctor. You can call the CMOH. You should have a nurse as well if you have a nurse at all, if you have any clinical staff. Or you can call the parent, discuss with the parent, and if you want, you have a little piece of gravel, particularly an older child, if the child is vomiting. And then let the parent take over from there. You have to have a plan. How do you respond when you find out that that same child who came to school was COVID positive? What do you do next? Well, certainly closing down the class is not, I don't think that that's acceptable, nor is it evidence-based, right? If it were that the child was closely intermingling with another child, what you do, and this is the UK guidelines, so I'll share with you the UK guidelines. Right? Yeah. Yes. For in terms of children, can medication be given to children at school? Right? Can medication be given to children at school? You call the parent, right? If the child is an older child, there's a question in the chat here, so I'm trying to address it, right? Panadol, you just pass it to the child's parent and you can administer some Panadol. You should have some schools will have a nurse. Now, these are essential provisions during COVID. You are supposed, by now, all schools should have an infirmary, some level of infirmary, even a basic infirmary with Panadol, right? By now, that should be in place. Yeah. So in terms of Panadol, I think that is something that the educators need to speak with, the principals. They need to get together and they need to discuss with the ministry or so what is the guidelines, because internationally you can give something as simple as that. So if it is, so if it is that you feel that you are not equipped to give a child who has a high fever and you call the parents and the parent says, administer 2 Panadol for my child, please. If you feel that you're not equipped to do that, that's a major problem. That is a major problem that needs sorting out now, right? Okay, so there's a debate about whether to give medications, no problem. Call the parent, let the parent pick up the child. But the question now arises, if the child has been diagnosed with COVID, what do you do? I would like to get some feedback from educators here. What is the right, what do you think is the right, what is the protocol that you have in place dealing with a child who has been tested positive? How do you treat with the classroom? Right. There are other hands, Deborah, if anyone else wants to contribute.
Hi, good night. Edward Moody here, former formal educator. The issue, Dr. Rajiv and others on the panel, is that most educators are not allowed to come out in the public like this and speak openly about the policies they have in the school. What we should do is be mindful of this. That's why you see some of them are not saying anything. And we should probably set up a phone number. I don't know if we are sharing any number or any contact email where these people could actually contact us, and we could probably give them guidelines or assistance privately going forward. What they could do is give the personal experience, but given the school experience at this forum, they may run into some trouble with the entire process of who is who in education. The second thing I wanted to say is, now I am seeing the people drop into 3:36, so maybe we could do that kind of early. The second thing is the medical and legal aspect of double masking, as we are hearing now in schools like Point Fort, some schools in Point Fortin and others where administrators are insisting that the children be double masked. So could you all say something about probably that legal aspect and the medical aspect as well? Because if a mask was designed with a certain density of fiber or whatever in it, how does double masking, how would that affect the child?
Well, double masking a child, once again, as I said, masking in schools, you know, I'm not convinced of the evidence for this. I know that we are living in a country where masking has been considered to be essential in containment or prevention of spread. But as I said, we do have the highest death rate in the world. I'm not saying that in a hyperbolic way. I'm saying that literally. Even though our schools were fully closed down, our masking policy, particularly, as I said, to me, it's not evidenced by success. But certainly with children, I don't think it's practical at all. Double masking, I mean, as I said, many schools, many places like the UK jurisdiction in the UK, they don't mask the children at all, right? So it's a very, very contentious subject. Double masking doesn't make any sense at all as far as I'm concerned, not children, right? Dr. Bratt himself said that he doesn't support masking in persons under 12. Neither do I. Neither do I. Does it help slow the spread? As I said, it's a mixed bag. If you actually listen to our own Minister of Health and you listen to Dr. Fauci, at the beginning, their position is that you're touching your face and it worsens spread and all that. The science, when they say the science, I'm really sorry, but there's no clear science on anything. And this term has been invoked in a way as a command without actually presenting any actual evidence behind the statements. It's being invoked as the science, but there's no particular specific science. As I said, recently there's a study that came out in Finland which showed that schools that masked their 10 to 12-year-olds did not have any increase in incidence in transmission among the children, or the secondary attack rate was not increased in adults. There was no increase in adult transmission in those towns either that did not mask their 10 to 12 years old age group. So, I mean, certainly double masking, I think that is just, it reflects a kind of neurosis, a kind of germophobia that our society has now acquired and has become the norm.
I don't want to lose the track of the conversation, but I know that someone had asked about the testing, so I just wanted the opportunity to touch on that very quickly. Every laboratory test, whether it actually happens in a laboratory or in your home or in a pharmacy or whatever it is, every laboratory test has a limitation and a set of parameters. Laboratory tests provide additional information that should be taken in the context of everything else. So defining a case of something based purely on a laboratory test without any other parameters that contribute to that conclusion is a bit of a risky venture. The PCR testing was all we had in the beginning. It was not designed to differentiate an infectious viral particle from a dead viral particle. So in and of itself, it was a bit iffy to be able to say that this person is COVID positive and therefore they are infectious. That's not what the PCR was designed to do, and it never could make that differentiation. The antigen test would be a bit more significant because an antigen test would be more likely to be positive if someone is actually producing an infectious substance, whatever the antigen test is picking up. We still have to be careful though, that until you have tested a particular technology in your population and in your environment, it is very difficult to say exactly how it is performing. We are still in the stages of trying out those antigen tests. We have some information. There are some things that we can say based on the information that we've analyzed so far, but there are still some questions that will need to be answered with more experience, because there are occasionally interfering substances that can cause a test to turn up positive. Not all brands of every test are as reliable as others, and so on. So all of these things still need to be sorted out. So the testing process has to be taken in the context of other information, an index of suspicion of infection and so on, and not by itself as a proof or unequivocal information stating that someone is infectious. I just wanted to say that.
Okay. Okay, just wanted to, we have a participant who's been asking about Miss C in children, and I was wondering if any of our panel could speak to this.
Right. So this was a conversation I was having with Dr. Bratt briefly as well. He had mentioned that it's vanishingly rare, at least with his practice. There are reports in Trinidad that we have a higher rate of Miss C than North America. The rate of Miss C in North America, I think they recorded 50 MIS-C deaths to date. In total, there are 1,100 deaths reported under 19 years by the CDC. 50 of those were in children with MIS-C. MIS-C is a condition that can affect children who are healthy. So usually you will say that COVID-19 only really claims the life of a child who has a severe illness, some kind of severe comorbidity, maybe cystic fibrosis, maybe some kind of severe lung issues from before or so, right? But MIS-C can occur in a healthy child. The MIS-C is something that is a clinical entity that develops a few weeks after contracting COVID. Should we be on the alert for MIS-C? Well, typically by the time a child develops MIS-C is multi-systemic inflammatory syndrome, right? Multi-system inflammatory syndrome. So typically the child will have unremitting fever. So they would have appeared to have recovered from COVID. Even a child, maybe they had a asymptomatic bout of COVID, almost asymptomatic, but they develop some fever a few weeks later, and then they can develop typically a rash and vomiting, right? Vomiting or abdominal pain. In Trinidad and Tobago, it's apparently a little bit higher in the persons of color. Generally speaking, more than 90% of children, once they are detected and treated, they will recover quite fine. It's rare. It's very rare, and it is not something that the general population should be overly concerned about. And I have to apologize that there has been a concerted effort to sensitize the public about this rare condition associated with COVID in children. But I fear that I am afraid that it is used as a kind of tactic to create fear among the public. It's very rare. It's not something you should be thinking about. However, if you see that your child has a fever and is not feeling unwell, don't try to diagnose MIS-C. Don't keep MIS-C in mind. Go by a doctor. Just go by a doctor and then let them make that diagnosis, right? But again, in terms of Omicron, is MIS-C a big deal in Omicron? Not really. Does the vaccine, is it a bigger deal in Omicron than the other variants? Not really. Is the vaccine going to solve MIS-C? If you look at the internet, if you go on to Google Scholar, you'll see that there was some data coming out in January that was saying that the vaccine reduces MIS-C by 98%, right? So in fact, what they said is that 2% of persons who had MIS-C were vaccinated. But that is because the time when they actually reported that data, only about 5% of the population, pediatric population, was vaccinated. So it is actually a sleight of statistical hand that you will see. We don't have any good evidence because we don't have any long-term evidence that the vaccine is going to stop MIS-C. All of this is still gray. The areas are very gray. Very, very limited evidence about MIS-C, about vaccination in MIS-C. And what I can say is, please do not fear, do not entertain that fear. Again, if your child has fever and so on, just take them to the doctor and let the doctors deal with that. It's too complicated, yeah, for parents to dig into that.
Yes, peace and blessings all. Good night. All right, I just want to make a quick testimony and one question. I'm a parent of 2 kids, both below the ages of 10. We all encountered what was documented as Omicron in the past 2 to 3 weeks. My children recovered. My son, the younger of the 2, he recovered in 2 to 3 days, actually 24 to 36 hours. My daughter, she recovered in about 3 to 4 days. My spouse, she recovered in 5 days, and I recovered in about 7 days. Right, now my question, Well, those of you who know me know what my major core is in my jaw right now. And that has to do with the mask wearing in the primary schools. I know Rajiv and Dr. Bratt both pronounced strongly on it, against it. But if you could touch quickly, I know because time is running, briefly on the effects of short-term and long-term of this mask wearing in the primary schools. I'm looking at a report from Dr. Paul Alexander. He indicates that there's chlorine, polyester, and microplastic components which might be harmful to the kids as well as adults. If you can touch on that quickly, and anyone on the panel, thanks.
I'm very much against masking also. And the younger the child, I'm even more so opposed to it. Contamination or the introduction of foreign bodies is never good for the human body. I would tend to agree that if these different chemicals have been identified, they certainly shouldn't be going into lungs, and they certainly shouldn't be going into young lungs. So I would raise that as an issue with a cloth mask, of course. If you wanted that, I would say, all right, I can't see any problem with that, apart from the fact that it's very well, disturbing for a child to be using that all the time. I hope I've answered your question there.
There's a lot of information now. People have begun to study masks and the effect of masks, particularly because of this pandemic and the divided views on it. There's a tremendous amount of information contradicting masks as a recommendation, and even when there is benefit, there are a lot of information suggesting that there's also significant risk, especially for long term, meaning like 8 hours a day in a mask and so on. Surgeons wear masks for a couple of hours and dish them, replace them, and so on. I'm pretty sure that most people who are wearing masks to work and so on are not changing them every couple of hours and so on. People are reusing masks, hanging them up somewhere, putting them back on, that sort of stuff. It's very difficult to tell exactly what's happening now. But we also have to look at the issue of the ability to breathe properly, which is important for everything, including your immunity. Lack of oxygen also depresses your immunity. So you're actually creating a situation where you are preventing people from being able to resist something should they actually be infected. So there are lots of pros and cons to the mask wearing. Overall, my interpretation of the data, I'm not qualified to pronounce on this, but my interpretation of the data that I've looked at suggests that typically, particularly extended mask wearing for the most of the day or whatever, and particularly while you are active, even walking in the street and so on, is not a good idea. There are probably more risks associated with that than benefits. But the literature are there.
All right. And before, at this time, I should say I would like to thank everyone this evening, our panelists, Dr. Seereeram, Dr. Bratt, Dr. Labastide, and Dr. Strisiver, and to Dr. Suchong as well for his contribution, and to all of you who have stayed with us until way past, we're almost 3 hours into this town hall. We want to thank you for your trust and your interest, and for being here a part of this evening. As I mentioned earlier, this is one of what we hope will be many more town halls on a variety of topics. I know that we still have many unanswered questions, but we hope that we have been able to enlighten the members or the persons from the education sector who are here with us this evening. And we would like to say to you that we try to provide the medical insight, but a distinction has to be made as to where the medical aspect ends and the administrative aspect begins. There are certain things that we can't address. For instance, someone asked, why aren't they using antigen tests, etc. These are things that, as people in the education sector, you will have to lobby for. We can't do that. We can only sort of direct. I'd like to invite everyone who's interested in hearing from us on a regular basis to please provide any contact information that they would like us to use to contact them, so that we may keep them in the loop as far as information and education and other sessions just like these. So please, if you'd like to be contacted, if you'd like to receive our newsletter, please send us your email address, or you can provide a phone number and you'll be included in our WhatsApp communications. Just a thought, something I wanted to share. Some months ago, Bill Gates was at a forum in Munich, Germany. It was a security forum, I believe, and he very offhandedly said to the audience that he didn't understand why everybody was making a fuss about wearing masks, because it's like any other article of clothing. You know, you wear pants, you wear shirts, so what's the big deal with the mask? And it was amazing that an audience of thousands, nobody thought to tell him that the mask covers the two parts of our body with which we breathe. No article of clothing, no other accessory does that. The mask simultaneously covers our nostrils and our mouths, the orifices through which we take air. So my question as we close tonight's town hall is, how can it be beneficial to us, or is it really beneficial to us, to cover and restrict the two orifices, the only two orifices from which we breathe? And with that, I bid you good night. We're going to have the room open for a little while longer to take your contact info. And I want to thank all the people who've already started to put their contact info in. And just to remind you that we'd like to apologize for any questions we may have not answered, but please do send them to our email address, which is info@ctag.org. That's CTAGTT.org, info@ctag.org. Or you can go to our website, which is ctagtt.org, and fill out our contact form, and we will contact you. And if you missed any of those addresses are available in the chat. I posted them earlier. And you can also join our Facebook groups, CTAG, CTAGTT, and VSAG, VISAGTT. That's our vaccine injury Facebook group. And through any of those platforms, you can contact us. So to all of you who joined us this evening, thank you. For those of us who stayed with us an additional hour, thank you so much for that. And we hope that we have provided some answers to your questions, some directions for you. And we hope that you all can trust yourselves, trust your judgment, believe in what you see, and take the action that you believe appropriate and that is within the guidelines that you must operate within as a professional. And above all, have courage and be kind. Good night.
Good night, everyone.